Ladies and gentlemen, dear colleagues and friends, on behalf of the European Society of Gynecology, welcome this afternoon. Today's webinar is about to start, and I would like to remind you that the views expressed in presentation made at the ESG webinar are those of the speakers and not necessarily of the European Society of Gynecology. Presentation of any information regarding any specific option, commercial product, or practices does not constitute an endorsement of the speaker or third parties' views, but products or services. You will be able to ask questions using the question and answer button at the end of, and we will discuss this question at the end of both presentations. This webinar will be live captioned via Wordly. To enable live captioning, please accept the prompt that appears on the screen. A window will appear on the right side, allowing you to select your preferred language. The presentation will be done, in any case, in English. And can I have the next slide? Okay. And today our webinar is EGGcellence in oocyte quality. And we have two speakers. One is Dr. Luis Vicente from Lisboa, and the other is Dr. Virginia Calvente from Madrid. I will introduce the CV of each one of them just before their presentation. And then as we will start with Luis Vicente, he is obstetrician gynecologist and specialist in reproductive medicine and coordinator of the Medically Assisted Procreation Center at Lusíadas Hospital in Lisbon. Is president of the Portuguese Society of Reproductive Medicine and vice president of the Portuguese Society of Gynecology. He has extensive clinical and scientific experience in assisted reproduction and female infertility. And then today he will speak for us on the EGGcellence in oocyte quality, mechanistic evidence supporting the golden ratio 3.6 to 1 of mu-inositol to dichiroinositol. That means 1,100 milligram of mu-inositol and 300 milligram of chiroinositol and antioxidant. Dear Luis, you have the microphone. And please, if you can share your screen with us, and then if you can start your presentation.
Thank you very much, Mr. Chairman, for your kind introduction. And it's a pleasure to be talking about EGGcellence and in oocyte quality, because all of us working in the reproductive medicine are deeply concerned nowadays in not only get as much more oocytes that we need in a stimulation, but also we are concerned to get a high quality oocyte, because we know that the oocyte quality is related with a good embryo quality and good embryo development. And that is related to a higher pregnancy chance to get pregnant. And that's the couple's goal, and that's our goal. So to understand ovary functioning, PCOS is a perfect model. So we have to understand how things work in the ovary so that we want to get as much quality as possible. So about PCOS, the first message that I would like to leave is that it's not so simple as it seems. So we have this criteria from the Rotterdam criteria since 2003, and it looks very simple. We get the criteria, but we know nowadays that it's a very heterogeneous population, and so all the patients are sometimes very different, and that's important to keep that in mind anytime that we are designing a study or any time that we are looking at the data from meta-analysis, because the patients are different, and so we cannot look as if they were only the one patient as having PCOS. So we have different phenotypes, and for instance, in phenotype D, this is not a metabolic, this is an intra-ovarian problem, and so it will be treated in a different way. So if you mix these patients with the others, we might be ending with a wrong conclusion in any study. And so even a very recent study published last year, and it was by clustering of more than 29 clinical variables to reach 9 important variables with these patients. And they started with a cohort of more than 11,000 women. And they've done it a follow-up for more than 6 years. And what they have seen is that there are really 4 subtypes or subgroups of PCOS patients, those that are hyperandrogenic PCOS, obese PCOS, SHBG PCOS, and those that are LH PCOS. And for instance, we know that in the clinical practice, this will have important meaning because, for instance, with the LH PCOS are the patients that have a high risk of OHSS. For instance, in hyperandrogenic PCOS are probably the patients that we are not doing the embryo transfer in the fresh cycle. And in the future, the rate of complications that they will keep with PCOS in the follow-up is different. So we have to keep in mind that these patients are not the same. So this is much more complicated than we previously thought about PCOS. So, but the female fertility and subfertility might be related with many topics, from genetics or age, and from diseases and metabolics diseases. And I'm going to focus in insulin resistance and in the lower sensibility of insulin receptors. So we know that the global prevalence of insulin resistance in the adult population is increasing, and it's estimated that around 26% is the prevalence of insulin resistance, and this must start to be a public health priority. So how can we in the clinical practice know if we have insulin resistance? So we have some indexes, but the most usable will be the homeostatic model assessment of insulin resistance, the HOMO-IR. It's an index that measures the glucose and the plasma insulin. So what we already know is that above 3.6 or 4.6 of this index, we are having insulin resistance. And in those patients, we should be using metformin from some years ago. But metformin is an insulin sensitizer, but with some lateral complaints with the patients. So it's not so easy to use. And we already know that always we can try to get as much as the patients more comfortable. So we also know that even below these thresholds, we are already having hyperinsulinemia. And that also is a problem because maybe if you are just starting to treat above that threshold, we might be losing some patients. So we already know from some works that if we take a look at the ovarian sensitivity for the stimulation in IVF, we already know that above 1.2 and certainly around 2.33 of this index, we are already having a lower sensitivity for the stimulation. So we have to keep in mind that it's not only insulin resistance, and maybe we also have to understand that there is a lower sensitivity to insulin is already a problem. And this is increasing the number of patients getting in this range. And from the NANT study, we know that from 2003 to 2001, there is an increased prevalence of these patients. And why? Well, because we are having toxic habits, we are having patients that are coming older, we are having patients with more increased visceral and abdominal adiposity, with nutritional imbalances, with the physical inactivity. So we have many environmental factors that are throwing our patients into insulin lower sensitivity. So we know that hyperinsulinemia can have an impact in oocyte quality. That's what we are talking now. So we know that the metabolism of the glucose is impaired. We know that the steroidogenesis is also impaired with higher concentrations of androgens. And also with hyperinsulinemia, we have an increased oxidative stress over the oocytes. And that leads to a lower oocyte quality. So if we are only treating above this threshold of 3.6, maybe we are treating only the tip of the iceberg of these patients. And we already know from some other works that even below that threshold, we have a reduction in pregnancy rate in PCO patients undergoing IVF. And also above 2.33, there is, as I've shown you before, a reduction of ovarian sensitivity in IVF. And even in the lower threshold, a reduction of pregnancy rates in patients undergoing IVF has already been published. So we have probably not to think only about insulin resistance above a higher threshold, but we also have to think that below that, with a lower insulin sensitivity, we are already having an impact in our patients. So if insulin sensitivity lowers oocyte quality, how can we treat these patients? So about inositols, we know that they are insulin sensitizers, but also they are second messengers of insulin in the cells, and they have a key point in the oocytes and also in those tissues that need a lot of glucose. So there are at least 9 types of these molecules. The those that are more known are myoinositol and dechirioinositols. So they are stereoisomers, so they are mirror image of the molecule. And we know that myoinositol, it's obtained from the diet, but it's also produced within the kidney. And the function is to facilitate the glucose absorption, and it allows the glucose entry into the cell. On the other hand, chiroinositol, it's not obtained from the diet, and it's usually the production is through the epimerase enzyme that turns the myoinositol into chiroinositol. And the function is to store. So myoinositol gets the glucose inside the cell, but dechirioinositol, it will store in the activating the glycogen synthase, and it allows the storage of glucose in the cell. So when we have high levels of insulin, the epimerase is blocked, and so there is not this conversion. So insulin as a whole, it regulates the glucose levels in the bloodstream, and it also induces the glucose storage. But the entry to the cell, it's facilitated by the myoinositol, and the storage then it's facilitated by the chiroinositol. So we have to keep this in mind. So in normal conditions, in the systemic, what it happens is that insulin usually gets connected to the insulin receptor that then activates these second messengers, and they are going to activate the epimerase, and there is a conversion of myoinositol in dechirioinositol, and that increases dechirioinositol. But when there is insulin resistance in the receptors, we have increasingly high levels of glucose, and insulin is going to increase but the insulin receptor is insensitive. At the same time, we are getting the epimerase blocked, so we are not getting the conversion of these molecules, and this will gets to have the chiroinositol deficiency, and we cannot store the glucose in the cells. But this is at the systemic level. So what happens in the ovary? The ovary never gets insulin receptor resistance. So there is a paradox of the chiroinositol in the ovary. What happens here is that during in the systemic, although the insulin receptors are resistant, it doesn't happen here. So as having higher levels of glucose, we are having higher levels of insulin, and that it's going to hyperactivate the receptor. And that in turn is going to hyperactivate the epimerase. And so we are going a very high conversion of the chiroinositol. And we are going to have excess of the chiroinositol in the ovary. So, and what is the problem with this? We know that in the theca cells and granulosa cells, these messengers are important for the conversion of androgens to estrogens. So myoinositol, it's going to increase when we have, and usually it's the relation between myo and the chiroinositol. So when we are having myo, we have more conversion to estrogens. When we have the chiroinositol rise, we have an increase in androgens, and also there is also a block in the epimerase, and it's going to block the aromatase that makes the conversion of testosterone in estrogens. And also we know here, and that's important, what happens here is that hyperinsulinemia also can trigger the LH receptor in the cells, and that's going to make a premature differentiation of the follicles or small follicles, and that is responsible for the arrest of the follicular growth. So keeping this in mind is that hyperinsulinemia, the key point to understand this is to understand that in the ovary, with this paradox, when we have insulin resistance, not in the ovary is going to happen. And so we are going to have increasingly formation of chiroinositol, and we are going to have an increase in androgens. And also that is going to impact the oocyte's quality. So is it true that if you supplement with the chiroinositol, it will seem that we would be accumulating more the chiroinositol? Well, but that's not true. So what happens when we supplement is that the chiroinositol facilitates the glucose storage in insulin-sensitive tissues like a liver muscle, and it helps to normalize the blood glucose levels. So this improves the systemic insulin sensitivity and leads to a reduction in circulating insulin levels. So as the insulin drops, it reduces that overactivity of the epimerase, and it's going to keep the balance between myoinositol with the chiroinositol to a more homeostatic level. So there is a normalization of these molecules in the ovary. So what is see that when we give this insulin sensitizer in the chiroinositol with myoinositol, we are going to lower the glucose in the blood. We are lowering the insulin levels in the blood, and so in the systemic level, this is the effect. But it also is going to decrease all of these, and is going to unblock, and this epimerase that is hyperactivating, it's going to disappear and restore its function, and you are going to have less the chiroinositol, and the balance with myoinositol will be more homeostatic. So just for keeping in mind, in the normal, we know that bio it's going to have the conversion to the inositol, but in hyperinsulinemia, in the systemic level, we have high levels of insulin going to down-regulate the epimerase, and we are going to have less levels of the inositol. But on the contrary, because of the ovarian paradox, we keep getting more insulin and we are keeping the epimerase hyperactivated and we are having high levels of the inositol. And when we are supplementing, we are lowering the systemic levels because we are getting the glycogen production and storage in the intracellular level, and so that it's going to lower the plasma and glucose insulin, and we are going to lessen the impaired glucose metabolism, and we are going to lessen the dysregulated steroidogenesis with not having so much androgens and less increased oxidative stress. So this, we already know that giving these inositols can have this impact that we are going to increase the more homeostatic environment in the ovary. But it's not quite simple. So what it's more different is that when we give the combination of mayo with myoinositol with inositol, it will works better than if we are going to give only myoinositol alone. So in this study, the combined use of these two molecules is superior to the use of myoinositol in improving lower levels of androgens, in having a better lower insulin resistance, and they are going to be lower when we get this combination. But even more complicating the things is that the relation or the amounts of each of the components, it's also different. There was once one to work with the 7 types of relations of between myoinositol and inositol that were in the formula. And in this work, we just seeing two, combining 40 to 1 or 3.6 to 1. Why 3.6 to 1? This is the estimated daily conversion of mayo to the inositol. And what is seen here in this paper, and I think Virginia will talk about it later, is that with the 3.6 to 1 inositol, we had a higher pregnancy rate, a higher number of live births, and with getting a metabolical response better than with the other formulation. So it's not only giving myoinositol alone, the combine is important, but also the amount of each of the molecules, it's also very important. So we are having differently pregnancy rates, number of live births, and lower OHSS rates in PCOS patients when we are using the 3.6 to 1 rather than the 40 to 1 relations of these two components. And probably this is related with higher oocyte quality, that it's not regarded with BMI or age. And it's with the cytoplasm quality that it's correlated with the embryo quality and implantation rate. So our thinking is around a lot through these years, we are coming from metformin, and then we are seeing that it's equally beneficial, although with inositols, we are having 84% fewer side effects than metformin. And then we have understand that if we are giving the combination of mayo with the inositol, it will be better. And nowadays, we are understanding that even the relation that they are combined is really very important to have the results that we are expecting. in ovocare, we also have more components that might be very important for us. And antioxidants, we are getting even more concerned about that. And because we know that we might need antioxidants in this environment of the ovary. So we know that it's going to work at the cellular and metabolicals in the mitochondria, and all of these components will be important to optimize the mitochondrial, the neutralization-free radicals, and it will be related with oocyte quality. There is also a new formulation that we can use in IVF that it's concerned about the microbiome, and here we are trying to get probiotics that will get a better environment so that we could get better IVF outcome, because we know that this dysbiosis can be different in fertile patients. So this can be a new step forward to our treatments that must be having more robust RCTs, but it's also a good point in this type of treatments. I'm finishing, and I would like just to say there was once this survey in Australia, and the survey involved the Polycystic Ovary Syndrome Association, and they've looked at all the patients, and surprisingly, 70% of them told that they use complementary medicine. So this is very high. So nowadays we are having patients that are even more informed. They are always coming with some data that they found, and so we never know, but maybe they are sometimes taking supplements that we cannot that we never know, that they are not telling us. And for that, I think that having a good formula, it's better for us to take the leads, and it's better for us to give you the right supplement than letting the patient getting the wrong supplement, because many times we see that we are not having the results that we are expecting. And when we ask the patients, they told us, well, I'm taking this and I'm taking this herbal tea, but maybe that it's not the wrong. So we have to take the lead in, if you want to supplement, at least we try to supplement with a good proportion. And you see in this lecture that it just not the component that's important. It's also the combination and the right ratio of the components that might be important for our results. And the goal is to get the pregnancy, so we have to take the good supplements and for our patients, and taking the lead to prescribing them and not letting the patients prescribe for themselves. So thank you very much for your attention.
Thank you very much, Dr. Vicente. Thank you for this lecture. And then it's now my pleasure to invite the second speaker. First of all, I would like to remember to everybody, please write your question in question and answer, and I will read that at the end of the Dr. Calvente presentation. She will lecture on clinical evidence one of menoxidil, dihydroinositol, and antioxidants. She's a gynecologist who specializes in assisted reproductive technology. She graduated in medicine from Complutense University of Madrid in 2012. Very young, mainly in comparison to me, and completed her residency at Virgen de la Luz Hospital in Cuenca. She has worked at Hospital del Henares and Herein San Jose, and she holds a master in assisted reproduction and has been part of Eugene Madrid since 2023. She also teaches at the European University Medical School, Ruber Juan Bravo. And Virginia, you will have the microphone, and please, I thank you for sharing your slides, and then you can start your presentation. And remember to everybody to write your question in question and answer, and we will answer later on at the end of Virginia Calvente presentation. Please, Virginia.
Thank you very much, and thank you for the invitation to speak today. So in this presentation, I will review the existing clinical evidence of the ratio 3.6 to 1 myo-inositol to the Cairo-inositol, and I will also present the findings from our study conducted in Ruber Juan Bravo under the leadership of Dr. Daniel Ordóñez, which provides additional support for this formulation. So let us begin with a brief overview of the physiology. As we know, insulin is a pancreatic hormone that regulates blood glucose levels by facilitating the uptake of glucose into cells. Under conditions of low insulin sensitivity, insulin receptors are not going to be activated properly, and glucose cannot enter the cells efficiently. This leads to elevated blood glucose levels, and in response, the pancreas may attempt to compensate by producing more insulin, resulting in hyperinsulinemia. At the ovarian level, low insulin sensitivity and impaired glucose uptake is going to disrupt the normal function of granulosa and theca cells. This will lead to altered steroid hormone production and impaired follicular development. This disturbance result in an ovulation, lower oocyte quality, lower fertilization rates and embryo quality, higher chances of implantation failure, and ultimately lower pregnancy rates. And this is because insulin is a key regulator of the reproductive axis, participating in the synthesis of multiple hormones. On the other hand, insulin also plays a central role in metabolic processes through its involvement in various signaling pathways, including the glucose metabolic pathway. But insulin does not work without inositols. Myo and the Cairo-inositols are second messengers, as we've already seen, in the insulin cascade. So insulin cannot function properly without them. Myo's main function is going to be glucose uptake, and DCI's main function is going to be glucose storage by glycogen synthesis. In normal conditions, the ratio of myo-inositol to the Cairo-inositol is 40:1 in plasma, while in peripheral tissues like muscle, liver, or adipose tissue, the ratio changes to approximately 2:1 or 3:1. This is due to the role of these peripheral tissues in glucose storage. DCI, as I just said before, promotes the storage of glucose in glycogen. So tissues that store more glycogen tend to have higher concentrations of DCI. However, under conditions of low insulin sensitivity, as PCOS, plasma levels of the Cairo-inositol decrease by approximately 50%, and its levels in peripheral tissues decline by up to 90%, whereas myo-inositol levels remain unchanged in both tissues. So the Cairo-inositol supplementation becomes necessary under conditions of low insulin sensitivity because both plasma and key peripheral tissues are deficient in this molecule. Moreover, the Cairo-inositol is not going to be obtained from diet. In fact, dietary sources are very low. And most of the body's the Cairo-inositol concentration is going to depend on the endogenous formation from the conversion of myo into the Cairo-inositol. But this conversion of myo into the Cairo requires an insulin-dependent enzyme, which is called epimerase, whose activity is going to be impaired when insulin signaling is diminished. So all these three things make supplementation with DCI necessary. But let's try to understand better why it is so important to supplement with the Cairo-inositol. So under normal condition, insulin binds to its receptor on the cell membrane, which activates the insulin signaling pathway. Following this, myo-inositol acts as a secondary messenger, promoting the translocation of GLUT4 transporters to the cell surface. This allows glucose to enter the cell efficiently. On the other hand, insulin-dependent enzyme epimerase converts myo into the Cairo, which induces glucose storage through glycogen synthesis. DCI activates the key enzymes such as glycogen synthase, so more glucose can enter the cell. But in conditions of low insulin sensitivity, the insulin receptor does not activate properly and the signaling pathway is impaired. As a result, myo-inositol is less effective at promoting the translocation of GLUT4 to the cell surface, and glucose entry into the cell is going to be reduced. Additionally, the activity of the insulin-dependent epimerase is also compromised, leading to lower conversion of myo-inositol into the chiroinositol. So this reduces the activation of enzymes like glycogen synthase, so less glucose is stored as glycogen. This is very important to answer our question about why it is so important to supplement with DCI, because under low insulin sensitivity, there is a drastic reduction in the chiroinositol conversion from myo-inositol. But what happens if we supplement with a 3.1 ratio or with 1,100 milligrams of myo-inositol and 300 milligrams of the chiroinositol? Supplemented myo and DCI enter the cell via other transporters. Myo works on the alternative pathway of glucose, and DCI works through the classical way of glucose. Supplemented myo will promote GLUT4-mediated glucose uptake, and supplemented DCI will activate the glycogen synthase, so more glucose can enter the cell. DCI acts like natural insulin, restoring insulin signaling, including the epimerase function and the GLUT4 transportation. This will then normalize glucose and insulin levels in systemic blood. So in conclusion, under low insulin sensitivity conditions, insulin will not be able to activate its receptor. Myo-inositol may help via the alternative pathway, but it is not able to restore insulin signaling without the chiroinositol. The chiroinositol mimics the function of natural insulin and manages to activate the receptor, even when this receptor is not responding to insulin. So now we know how important it is to supplement with DCI, but what is the amount of D-chiroinositol that should be supplemented? Until now, two major ratios have been studied in clinical trials, the 40:1 and the 3.6:1 myo-inositol to D-chiroinositol ratio. The key difference between them lies in the amount of the chiroinositol. In fact, the 3.6:1 ratio contains 300 milligrams of the chiroinositol, while the 40:1 ratio contains only 25 milligrams. This means that the 3.6:1 ratio contains 12 times more the chiroinositol than the 40:1. But why 40:1 or 3.6:1? Well, the 40:1 ratio assumes that the reduction of the chiroinositol due to insulin resistance happens only in plasma by 50%, as I said at the beginning. So supplementation with 40:1 is intended to mimic the physiological plasma balance to restore homeostasis. Sorry. On the other hand, the 3.6:1 ratio not only targets the restoration in plasma, but also the reduction that takes place in peripheral tissues, which is even more drastic and goes up to 90%. Assuming that the physiological conversion from myo to the chiroinositol in normal conditions is around 8 to 9% in peripheral tissues, and that myo is synthesized endogenously at an estimated rate of 2 grams per kidney per day, it is expected a production of approximately 300 milligrams of the chiroinositol daily. So let's check the evidence around these ratios. This randomized double-blind controlled clinical trial was performed to test the 3.6 ratio versus the 40:1 one. In this trial, in fact, the only difference is the concentration of the chiroinositol. It tests 60 patients diagnosed with PCOS undergoing EGGcellence, and they studied direct parameters like pregnancy rate, number of live births, testosterone, and insulin resistance. And what they saw is that supplementation with higher doses of the chiroinositol demonstrated a significant improvement in pregnancy rates and live birth rates. And they also saw a reduction in ovarian hyperstimulation syndrome. In terms of oocyte quality, the 300 milligrams of the chiroinositol formula improved especially the quality of the cytoplasm, which directly correlates with embryo quality or implantation rates, but also improved the perivitellin space, the plasma membrane, and the injection cone. These studies of Mendoza, along with other studies, also demonstrate that the 3.6:1 combination improves metabolic parameters like hyperandrogenism and low insulin sensitivity, measured by the OMA index and plasma insulin. In this retrospective study, including 283 women with PCOS, they showed how after using daily doses of the 3.5:1 ratio, insulin in plasma was reduced significantly and how the OMA index was also improved. And finally, this other study performed on 70 women with PCOS demonstrated how the 3.6 ratio also reduced fasting insulin and improved the OMA index. So if we go a step further and combine these inositols with antioxidants such as melatonin, polyphenols, and other vitamins and minerals, which reduce oxidative stress, the results can be even more remarkable. That is why we decided to test the combination in an observational retrospective pilot study. So we wanted to check if patients with PCOS could benefit from the 3.6 Mayo to decaro-inositol ratio treatment at least 1 month prior to ovarian stimulation. The study included 92 patients with diagnosed polycystic ovary syndrome according to Rotterdam criteria. They were all stimulated with an antagonist protocol, and they had minimum 15 mature oocytes retrieved via womb pickup. These patients were divided into 2 groups, one supplemented with a 3.6 Mayo to decaro ratio-based food supplement at least 1 month prior to stimulation, and the other one with basic supplementation with folic acid. All oocytes retrieved were fertilized by intracytoplasmic sperm injection, and the outcomes analyzed were the number of oocytes retrieved, the percentage of metaphase 2 oocytes, fertilization rates, pregnancy rates, and the number of cycles with at least 1 good quality embryo to transfer. So patients started supplementation at least 1 month before ovarian stimulation. All patients went to oocyte pickup when at least 1 follicle reached 18 millimeters, and all oocytes retrieved were fertilized by ICSI and cultured in single medium until blastocyst stage was reached. 92 patients participated. The mean age was 36 years old, and both groups were statistically homogeneous in terms of patient age and oocyte recuperation. And what we saw is that the use of food supplement with inositols 1 month prior to stimulation significantly enhances the fertilization rate in 6.5%. And it significantly promotes a 4-fold decrease in the number of cycles without any competent blastocyst to transfer. On top of that, the supplementation with 3.6 Mayo to the Cairo ratio, an antioxidant-based food supplement, improved significantly the clinical pregnancy rates from 42% in group 2 to 54% in the supplemented group. It also improved the ongoing pregnancy rates from 36% to 45% in the supplemented group. So our results indicate that the supplementation with a 3.6 to 1 myo-inositol to decaro-inositol ratio-based food supplement at least 1 month prior ovarian stimulation in women diagnosed with PCOS undergoing ICSI compared with no supplementation significantly enhances the fertilization rate and promotes a 4-fold increase in the probability of having at least 1 good quality embryo to transfer, possibly related to an improvement in oocyte quality. They show statistically significant improvements in clinical and ongoing pregnancy rates. And just to conclude, for important takeaway messages, the first one is that under low insulin sensitivity, patients present low levels of the decaro-inositol and supplementation is required. The decaro-inositol mimics the function of insulin, restoring proper insulin signaling. A dose of 300 milligrams of the decaro-inositol is a physiological, safe, and rational dose, and the 3.6 to 1 ratio, or what is the same 1,100 milligrams of myo-inositol to 300 milligrams of the decaro-inositol, has been clinically proven to improve metabolic and reproductive parameters. Thank you.
Thank you very much, Virginia, for that beautiful and very clear presentation. If you can close your
Yes.
echo, and then we will see each other, and then we can start the question session. I would like to invite Luis Vicente, please, if you can join us.
Yes.
And then I would like to start with you with a question. And okay, please, I invite everybody to try to write their question. The first one is for you, and it's from an anonymous, as this happened. Do you consider that inositol supplementation can benefit not only women with polycystic ovary syndrome, but also those without PCOS who have insulin resistant or metabolic disturbances? As you know, the overweight now is an epidemic in the world. And how you identify those who will respond best?
Well, so as I've shown you, it's not only the getting insulin resistant patients. We are always have to start to be concerned about lower insulin sensitivity patients, because we know that below that threshold, we are still having lower outcomes of pregnancy. So we are going to use that in other patients, and not only in PCOS patients. Maybe we are also in those patients that have a bad embryo development and with a bad quality of oocytes, and we are getting women that are older and those patients that have run through multiple cycles with lower implantation rates. And so I think it's wise also not to be only concerned about myo-inositol. And so we are going to correct the hyperinsulinemia. And so not only insulin resistance, but also lower hyperinsulinemia. And we are also have to be concerned about antioxidants, because we are getting older patients, and those are the ones bad responders that maybe if we increase the quality of the oocytes, we are going to increase the chances for those couples to get a pregnancy. So maybe with our environmental and less exercise, that we also always want to people to take the message to not to leave that behind, but maybe we might be ending to supplementing. So Mayo, it's not going to be a one only treatment. So it's an adjunct to our treatment plan. So that's how I see the use of in the clinical practice.
Thank you very much, Luis. No, this is fundamental. Your reflection also on who is the general population with infertility will join us. Normally, for this population, most of them they have already had during their life many aspects who are against normal fertility. One is less physical activity. One is increased body weight and increased adipose tissue, and also it's increasing in the age. And then it's very important to reflect as you are doing. And I would like to ask you now to Virginia. In your presentation, you recommend relatively high doses of the herein as 300 milligrams. Could supplementing with such high dose of the herein should be any harm effect?
So it's true that data suggests that very high doses of the carrainositol, such as 1,200 up to 2,400 milligrams per day, may be detrimental at the ovarian level, with reports that talk about a reduced number of mature oocytes and fewer top quality embryos to transfer. But in our case, we use 300 milligrams per day, which is substantially lower than those high doses that they used. They are administered within a balance with myo-inositol, which is also important. So I think it's a safe dose.
Certainly. And then it's in any case important to administer together with myo-inositol also. Okay, thank you very much. And then now, Luis, for you, in patients with subclinical insulin resistant but regular cycle, do you consider inositol supplementation to prevent metabolic or reproductive complication? Also, metabolic are very important.
Yes, it's important. And as I show in this recent paper, is that these patients are going to have metabolic problems, and we have to look after them. So not only for pregnancy, but later in life, they must be follow up.
Yes.
But in the context of fertility, I believe that we have to. My key message is that we have to leave behind the idea of only insulin resistance. We have to talk about a lower sensitivity to insulin, and so the OMA index of insulin resistance, we have to go to a lower threshold, because we are. If you are giving those patients a way to correct that lower insulin sensitivity, we are going to improve the oocyte environments, steroidogenesis in the ovary, lower androgens, and the quality of the embryos of the oocytes, and for sure the embryos will be better.
I'm sure. I would like that all those are our followers have to follow you and to take care of your suggestion, because this is not only during the fertile time, but also during the menopause. After menopause, also we have to try to take care of this good suggestion. And Virginia, for you, in the study that you presented, you mentioned that antioxidant were added to this the herein and immunogenicity ratio. Do you think that the antioxidant make a difference in the positive result obtained?
Well, it is very plausible that they contributed, especially because oxidative stress is very relevant in our patients and in reproductive dysfunction. And we know that several antioxidants have clinical data suggesting their benefits, no? For example, melatonin. But that said, because our formulation combines both of them, inositols and antioxidants, we cannot fully isolate the independent effect of antioxidants. What I think is that they both sum up, no? They both add, improving the oxidative environment, the antioxidants, while the inositol maybe helps with insulin signaling and endocrine balance.
Thank you very much. And then now we have a question from Precisa San Martin. And then she asked, thank you for the speaker for such an excellent and insightful presentation. Regarding the clinical application, how long would you recommend continuing supplementation with 300 milligrams of inositol for optimal results? Luis?
Well, hearing from the study from Virginia, well, we started at least 1 month before going to the treatment. And so I think, Virginia, what do you think about it?
Yes, in our study we started 1 month prior the stimulation, but we don't have like we use it so during all the study in patients when they did another pickup, they continued using it without problems.
Yes, because this is also my question. This is for the first month, but then if the patient she don't become pregnant, I suppose that you continue with that one.
I believe that in the RCT that from Mendonça, I believe that some of the patients they got pregnant before they entered the study when they started with the supplements. So it's also important that too.
Thank you. And then now, Luis, also, do you adjunct inositol therapy based on body mass index, age, or severity of insulin resistance? And what guidance do you follow?
Well, there is not a great consensus about which index is better, but I believe that the OMA it's the homeostatic model assessment of insulin resistance. That is the best one to look after that. And so we can ask that when we do a blood test in our patients and then go into those thresholds. And above 2.33, I believe that it's the time to supplement.
Thank you. And then now another question, and this is for Virginia. You mentioned that altered insulin sensitivity affect both peripheral tissues and the ovaries too. How can the inositol in peripheral tissues help to restore metabolic balance and improve ovarian function and fertility, since its concentration is high in the ovaries?
Yes, this Dr. Vicente explained that. It's because of the ovary paradox
that if you go still on it, because it's a key point.
It's true that the ovary behaves differently from peripheral tissues because it remains relatively insulin sensitive. And as we've seen in insulin resistance, peripheral tissues respond poorly to insulin and produce less DCI due to the impaired conversion of myo into DCI, because the epimerase is not able to work correctly. But in contrast, during hyperinsulinemia, the ovary can become overstimulated, producing more DCI than needed. But we think that if we restore the metabolic homeostasis in peripheral tissues, we can reduce hyperinsulinemia systemically, and once circulating insulin levels normalize, the ovary is no longer exposed to that constant overstimulation. So the epimerase activity gets to normal and the concentration of DCI too.
Hopefully, we believe. And then now the last question. This is, Luis, for you. And based on current evidence, how do you integrate in to improve both metabolic and reproductive outcomes? And which patient profile are most likely to benefit from this approach?
Well, I think that for instance, with Ovasi Care, I think that we have to look after not only as an insulin sensitizer that, like for instance with metformin, but also we have the activity of antioxidant activity, and so maybe we are going to have these patients chosen not only for insulin sensitivity or resistance, but also for bad responders patients, older patients, and patients that have done several attempts with no pregnancy. But usually when we are having patients that are going to an IVF cycle and that they want to improve all of their chances to get pregnant, maybe all of them are going to end up with getting some supplements. And I've shown in Australia, I get very surprised. 70% of the patients, they recognize that they were taking supplements, not telling their doctors. So, and it sometimes happens that we are sometimes doing our stimulation and we are not having a good response. And then I remember, okay, there might be something wrong here. And when we ask the patient, they tell us, "Oh, I'm taking a herbal tea that I've read in the internet that it's good for fertility, and it's not working well." And we stop it, and it's okay. So, as I've told, I think it's better for us to take the leads in choosing the right supplement. So, if we know that all of those patients are taking these supplements, why don't we use the right one? So it's time for us to think and help the patients to choose the best one, and not letting them choosing by themselves in the in the social media. So I think it's really important for us to take the supplement that can help us and can help the patient.
Thank you. No, I totally agree with you. But the supplement history is something that we have observed in most of part of medicine in general. But also, if you see also in anti-aging medicine, first is interpreted by the individual, not so much the patient, but the individual. They go on the website, they go on internet, and they try to explore what kind of substance that they can take to try to have an help. But I agree totally with you. This is wrong. This is wrong. They have to go to the doctors. They have to be aware what they infect. They can take it and why and for how long and what they have to be the goal. But now, dear friends, we are at the end. And then I would like to thank you very much. I would like to ask you a final message. We will start now from the younger, from Virginia. Virginia, I would like that with your experience in that chapter, you are a young person working with most of the individuals who are even a greater age than you and facing the problem of infertility, and then which is touching our society so strongly, mostly because we have lost the good time, because the best time for pregnancies was around 18, 19, 20 years. I am sure if all these couples, they can have check and try at the time, they will become fertile, certainly. But what is a suggestion that you would like to give? And later on, Luis, a final message from you for this very nice and helpful webinar that the European Society of Gynecology have organized. Thank you very much. Then Virginia.
So the message would be to search for help and talk with us because we are aiming to help them, of course. And on top of that, if we can look for a pregnancy before and try to change things in society, that would help too. But sometimes it's very difficult.
Unfortunately, yes. And then Luis.
Well, I think that in this fight against infertility, all weapons are welcome, and trying to get egg excellence and with very good oocyte quality is our focus. And we have to take all the medications, supplements that can have a synergic action to improve our results. In the end, it's a win-to-win situation. The patients win, they get pregnant, but we also win because we get a patient with the pregnancy.
Thank you. Thank you. Thank you very much, Luis, and thank you, Virginia, for this beautiful workshop. And I would like to thank also all those who have participated to our workshop. And this workshop was supported by Procare. And I would like also to mention that the European Society of Gynecology will continue its program of webinars, and I will invite all of you to join us in our next webinar. Thank you very much. Thank you, Virginia. Thank you, Luis.
Thank you.
Have a good day and enjoy your time. And my compliments for your action to try to help humans facing the fertility problem. And not only. Thank you very much and goodbye. Have a good day.
Thank you. Bye-bye.
Thank you.
Bye-bye.